We know that germline status, particularly BRCA1 and 2, is important, and that guides treatment with regards to PARP inhibition. We know that probably somatic alterations in HR genes or homologous recombination related genes such as BRCA1 or 2 or other DNA damage repair genes such as PALB2 will probably also predict response to PARP inhibition and other agents that target that pathway. So that's the first segment of TNBC that people should be looking for. Secondly, there's some data with regards to PI3 kinase alterations and PTEN and AKT. So again, sequencing of the patient's tumor is really important. And there's probably a scattering of other rarer mutations, such as HER2 mutations, for example, AKT1 mutations that will be important also for these patients. There are trials ongoing, but so far the early data looks great. And then there are some new agents now which are coming out, such as the antibody conjugates. So it's important to also know what the HER2 IHC status of these patients are, so +1, +2, because there are trials for these patients. So I think that's also important. And then finally, PD-L1 and TIL is also important for these patients as another biomarker. But certainly we are encouraging sequencing or molecular sequencing of the tumor and or plasma for all patients that recur with triple-negative breast cancer. You do not want to miss the BRCA1 or 2 mutation, for example, and you may find other things. Very rarely you might pick up some things such as mismatch repair status, which is potentially amenable to PD-1, PD-L1 agents. If we don't find anything for some patients, we are doing whole genome sequencing because we could find potentially mutational signatures, which may also be helpful, such as signature 3, which could potentially suggest responsiveness to PARP inhibitors, for example. So this is obviously a new world that we're in, but we strongly encourage people, if they can access molecular sequencing for their tumours when they relapse.